Hello, my name is Bob Fontana. I'm a professor of internal medicine at the University of Michigan. And on behalf of the CHIOMS Hepatotoxicity Working Group, I'd like to welcome you to our podcast on drug-induced liver injury, Lesson 2, Assessing Dili Cases. The goal of this particular module is to learn how to assess a Dili case report and enter valid data on the diagnosis, severity, and causality into an ICSR management system. Now, what are standard serum liver safety biomarkers? I'm sure you're all familiar with these: serum AST, ALT, alkaline phosphatase, and total bilirubin. Now, we know that these enzymes are released in the setting of liver injury. However, they can also be released in the setting of either heart or skeletal muscle injury, bone injury with elk phos, and also from hemolysis in patients with blood disorders. Therefore, they're not entirely hepatic specific, and you need to consider extrahepatic causes on a case-by-case basis. Furthermore, we know that there are reference values for these in a general population. Some of which are stratified by gender. GGTP is sometimes used in clinical trials, although it's not as reliable as alkaline phosphatase because it may nonspecific increase with smoking, alcohol use, and certain medications. Now, how do we identify and characterize Dili in clinical trials? This is a series of stepwise assessments. First, you always look at the baseline liver biochemistries in your patient population of interest, and also look for the presence of underlying liver disease, for example, hepatic steatosis in a diabetic population in a clinical trial. In terms of the risk of Dili, you need to know what the preclinical profile is of the compound of interest, and also what in vitro testing informed you regarding hepatotoxicity risk. Typically in phase 1 studies, which are done over 4 to 8 weeks for dose finding, weekly labs are obtained, whereas in phase 2 and 3 clinical trials, labs may be spread out, particularly in the maintenance phase, to every month or two. Now, in analyzing the likelihood or the risk of Dili, one looks at the incidence, timing, and severity of these liver safety biomarkers in the various treatment arms. Certainly, if it's a placebo-controlled trial, it's very straightforward, or if there are multiple doses or an active comparator, it can become a little bit more complex. But nonetheless, per protocol, predefined laboratory criteria are set up in advance to determine when an investigator should repeat liver biochemistries, when they should consider holding a dose, or when they should permanently discontinue. Now, it's important, no matter what these criteria are, to recognize that clinically significant Dili, particularly in a clinical trial setting, is always defined as an elevation in the total bilirubin greater than 2 times upper limit of normal, any elevation in INR, or hepatitic symptoms. The FDA and other regulatory agencies frequently will plot individual patients with regards to their ALT elevation on the x-axis and their total bilirubin elevation on the y-axis to form what's called an E-dish plot. And from an E-dish plot, you can determine the proportion of patients who meet Hy's Law criteria, which is acute hepatocellular injury defined as an ALT of greater than 3 times upper limit of normal, normal alkaline phos, and a total bilirubin of greater than 2 times upper limit of normal. We know from prior studies that Hy's Law cases portend the significant risk of Dili should the drug be released in clinical practice. All that being said, interpretation of a large data set of several thousand patients regarding liver safety biomarkers can be complex, and therefore an expert adjudication panel may be needed. Now, in terms of an individual case, what should be recommended in terms of evaluation? There's generally a first round of tests to exclude things like hepatitis A, hepatitis B, and pancreatic biliary disease, as well as alcohol, autoimmune hepatitis, ischemia, and sepsis through various lab tests, imaging tests, and clinical history. If an answer for competing cause of injury is not identified here, then a second round of testing may be done on a case-by-case basis. Now, in terms of the severity of a given Dili episode, there are three largely used and recognized scales for severity. The Dillon scale, which was published in 2009, is really intended for post-marketing studies more so than clinical trials, and it really ranks things from scale of 1 being mild to 5 being fatal or liver transplant, based upon the frequency of a bilirubin being elevated or INR, whether the patient was or wasn't hospitalized, and whether there was evidence of liver failure. The International Working Group on Dili also has a similar scale, but its only range is from 1 to 4, but similar criteria. And then the CTCAE, which the National Cancer Institute uses for all of its oncology trials, uses actually different combination of both laboratory as well as clinical criteria to grade the severity of liver injury. And this can become somewhat problematic because of the mixing of both laboratory and clinical criteria, whereas these other ones are simpler, and the Dillon scale gives you a range of 1 to 5, whereas the International Working Group is 1 to 4. Acute liver failure across the board, though, is defined as the development of an INR greater than 1.5 with mental status changes in a patient without prior liver injury, which portends a poor prognosis. Now, on a case-by-case basis, in addition to excluding competing etiologies, you can try to score a case. Three of the most commonly used scoring systems for that are Dili specific are the RUCAM score, which was published in 1993, Expert Opinion, which was codified by the Dillon Network in 2009, and then the more recent development of the revised RUCAM or RECAM, which was just published in early 2022. You can see that these instruments have various numerical scoring ranges, -10 to +14 on the RUCAM, -6 to +20 on the RECAM, and then the Expert Opinion is a simple 1 through 5 hierarchy of definite, of being greater than 95% probability to less than 25% in a given case. Now, what are the advantages and disadvantages of these? Well, there's been a few studies comparing them. The RUCAM is widely used in the literature, so it's widely published, but as on an individual basis, it can be difficult to complete due to complexity of the instructions. It's not entirely clear that the risk factors of age, alcohol, and pregnancy are evidence-based. And in some prospective studies, there was a lower rate of inter-rater reliability compared to the Dillon Expert Opinion methodology. However, the Expert Opinion methodology is not generalizable since it requires a series of experts in order to do this. The RECAM was just recently published and developed off of prospective data from both the US and Spanish networks. The advantage of this is that it's computerized. It pulls in information from liver tox from drugs already on the market, but it needs to be further validated. It's currently only been developed for single drug cases. Now, what about the role of liver biopsy in Dili diagnosis and prognosis? We know that in the liver, drug-induced liver injury can cause a variety of phenotypes of liver injury, from mild hepatitis to steatosis, necrosis, inflammation, and so on. So there's not one pathognomonic feature that would tell us that it's a drug-induced liver injury versus other causes of liver injury. However, it can oftentimes be helpful to help differentiate, for example, drug effect from underlying liver disease in your patient population and or sporadic autoimmune hepatitis. And it generally is used in patients who have more severe Dili, such as those who are jaundiced or have protracted and ongoing liver injury despite stopping the drug. In terms of Dili prognosis, There are a couple of useful histologic features, such as the presence of eosinophils and granulomas on the biopsy that are associated with a greater likelihood of recovery, whereas patients who have necrosis and or fibrosis are more likely to suffer adverse outcomes during short-term follow-up. So with that, I'd like to refer you back to Chapter 2 in the CHIOMS hepatotoxicity monograph. There's much more information than what we can provide in this mini podcast. We hope this is helpful. We all can work together to make medicines safer for patients. Thank you.